Good evening, Dr. Phil here. Today we'll be discussing on opioid use in anesthesia. Opioid use for general anesthesia. Kindly refer to the discussion on individual opioids such as fentanyl, remifentanil, and morphine in previous videos. Opioid use neuraxially. This involves administration of opioids in the epidural or subarachnoid space to treat acute or chronic pain. Opioid administration into the epidural or subarachnoid space has become widespread since the first report of epidural morphine administration in humans in 1979. Opioids in common neuraxial use includes fentanyl, which is widely used in the UK, morphine, diamorphine, and sufentanil, which is commonly used in USA. Site of action of neuraxial opioids. They act at the dorsal horn of the spinal cord and at supraspinal areas of the CNS. At the dorsal horn of the spinal cord, this is the main site of action of neuraxially administered opioids. These opioids are intended to target MOP opioid receptors present in the substantia gelatinosa of the dorsal horn of the spinal cord, thus modulating pain pathways. Activation of presynaptic MOP receptors on primary afferent neurons carrying nociceptive information results in reduced conductance through voltage-gated calcium channels, reduced calcium influx, reduced neurotransmitter release, and reduced signaling between primary and secondary afferent neurons in the dorsal horn of the spinal cord. Activation of postsynaptic MOP receptors on secondary afferent neurons results in hyperpolarization and reduced propagation of action potentials. A spinal rather than peripheral site of action is more significant due to a high CSF to plasma drug ratio and the low doses required compared with IV administration. Supraspinal areas of the CNS is another site of action for neuraxially administered opioids. These opioids are transported supraspinally by bulk CSF flow, where they modulate descending inhibitory pain pathways. For intrathecal opioids, a small amount of intrathecal opioid diffuses into the epidural space with subsequent systemic absorption, resulting in centrally mediated analgesia. This constitutes a minor effect. For epidurally administered opioids, the epidural space is highly vascular, and absorption of epidurally administered opioids via the epidural venous plexus into the systemic circulation results in a more significant contribution to centrally mediated analgesia than intrathecally administered opioids. Systemic concentrations of morphine, fentanyl, and sufentanil are similar when an equivalent dose is administered via intramuscular route versus epidural route. Lipophilic opioids such as sufentanil and fentanyl are absorbed the most rapidly, and they are more likely to cause early respiratory depression. Pharmacokinetics of opioids administered into the epidural or intrathecal space. Opioids placed in the epidural space undergoes diffusion across the dura into the CSF, uptake into epidural fat, and systemic absorption via blood vessels. Due to absorption into the systemic circulation via venous plexus in the epidural space, systemic concentrations of morphine, fentanyl, and sufentanil are similar when an equivalent dose is administered via the intramuscular or epidural route. The lipid solubility of an opioid administered neuraxially determines the extent of its cephalate movement in the CSF, its onset of action, and the duration of action. For less lipid-soluble opioids such as morphine, they remain in the CSF longer and migrates to more cephalate locations. Thus, morphine, which has a low lipid solubility, has a higher incidence of nausea, vomiting, pruritus, urinary retention, sedation, and delayed respiratory depression when compared to fentanyl, which is more lipid-soluble. More lipid-soluble opioids such as fentanyl and sufentanil are limited in their cephalate migration due to uptake into the spinal cord. Regarding the onset of action, highly lipid-soluble opioids such as fentanyl, sufentanil, pethidine, and diamorphine have a fast onset of action as they cross the CSF and bind to the spinal cord rapidly. Only a small amount is available to diffuse throughout the CSF. Epidural boluses may result in early respiratory depression due to systemic absorption. For poorly lipid-soluble opioids such as morphine, they have a slower onset time. They are slow to bind to the dorsal horn receptors in the spinal cord due to its poor lipid solubility. The onset of action of intrathecal fentanyl is 5 minutes, for epidural fentanyl is 10 minutes, for intrathecal morphine is 15 minutes, for epidural morphine is 30 minutes, for intrathecal sufentanil is 2 to 3 minutes, for epidural sufentanil is 4 to 6 minutes. Diamorphine, onset of action is less than 10 minutes. For intrathecal petidine, onset of action is 5 minutes, and epidural petidine is 10 minutes. Regarding the duration of action, highly lipid-soluble opioids such as fentanyl, sufentanil, petidine, and diamorphine have a shorter duration of action since they are more rapidly absorbed into the blood. Post-operative analgesia is thus limited by their short duration of action. Highly lipid-soluble opioids are more likely to act via systemic absorption. For poorly lipid-soluble opioids such as morphine, they have a longer duration of action. Special extended release preparation for epidural morphine exists. It consists of morphine sulfate pentahydrate encapsulated within 20 micrometer diameter liposomes suspended in normal saline. Onset of action is 3 hours with a duration of action of 48 hours. The dose for a single lumbar epidural injection is 10 to 15 mg. The duration of action for neuraxially administered opioids: fentanyl 2 to 4 hours, morphine 12 to 18 hours up to 24 hours, sufentanil 1 to 3 hours. Some sources quote 2 to 6 hours. For diamorphine, 6 to 8 hours up to 20 hours. Petidine 6 to 8 hours. Buprenorphine 8 to 10 hours. Methadone 4 to 6 hours. Advantages of neuraxial opioids. Neuraxial opioids provides more profound and long-lasting analgesia than systemic opioids. There is an increase in quality of intraoperative analgesia and prolonged post-operative analgesia. Unlike neuraxial local anesthetics, neuraxial opioids lack sympathetic, motor, or sensory blockade and are able to provide analgesia distant to the level of injection. Maximal analgesia corresponds to the level of injection of neuraxial opioids. Lumbar administration of neuraxial opioids has been used for analgesia after thoracic surgery. The cephalate spread of a neuraxial opioid depends on its lipid solubility, as discussed previously. There is a synergy between neuraxial opioids and local anesthetics. Opioids and local anesthetics are synergistic in producing analgesic effects when administered neuraxially. This is why spinal opioids are often mixed with local anesthetics. Neuraxial opioids allows the dose of LA to be reduced. This results in reduced motor block, reduced sympatholysis and hypotension. There is reduction in the regression of sensory blockade, increased quality of analgesia, and reduction in the number of failed epidurals due to patchy blocks. These mixtures can be given by boluses or infusions. Examples of epidural infusions for post-operative analgesia and chronic pain management: 0.1 to 0.2% levobupivacaine plus fentanyl 2 to 4 mcg per ml, running at 5 to 15 mL per hour epidurally. 0.1 to 0.2% levobupivacaine plus diamorphine 50 to 100 mcg per ml, run at 5 to 15 mL per hour epidurally. 0.2% ropivacaine plus fentanyl 2 to 4 mcg per ml, run at 5 to 15 mL per hour epidurally. Epidural opioid infusions alone are rarely used. Epidural petidine. Petidine has local anesthetic properties and has been used as the sole agent for spinal anesthesia and epidural infusion. However, when used for spinal anesthesia, there is a marked increase in incidence of nausea and vomiting. Doses. The appropriate dose depends on the route of administration, such as epidural or intrathecal. Intrathecal doses are usually approximately 1/10 of the epidural dose, as intrathecal opioids have direct access to the central nervous system. The dose also depends on the type of opioid, potency, efficacy, and lipid solubility. the indication of neuraxial opioid, and whether other adjuvants are added during neuraxial anesthesia or analgesia, such as local anesthetics, sodium bicarbonate, vasoconstrictors, alpha-2 adrenoceptor agonists, cholinergic agonists, NMDA antagonists, or GABA receptor agonists. For epidural buprenorphine, the dose is 60 to 300 mcg, epidural diamorphine 1 to 5 mg, epidural fentanyl 50 to 150 mcg, epidural methadone 4 to 8 mg, epidural morphine 1 to 8 mg. Be cautious and utilize only preservative-free morphine for neuraxial anesthesia or analgesia. Epidural petidine 25 to 100 mg, epidural sufentanil 10 to 75 mcg. The dose for intrathecal buprenorphine is 25 to 50 mcg, intrathecal diamorphine 100 to 300 mcg, intrathecal fentanyl 10 to 25 mcg, intrathecal methadone 0.5 to 2 mg, intrathecal morphine 100 to 400 mcg. For post-caesarean section analgesia, both single-dose intrathecal and epidural morphine have been shown to have a sealing analgesic effect. Morphine at doses of 100 mcg or more intrathecally and 3.75 mg or more epidurally, there is little additional analgesic benefit but increased incidence of adverse effects, especially pruritus. The dose for intrathecal petidine is 10 to 100 mg, however this is not recommended. The dose for intrathecal sufentanil is 5 to 20 mcg. Adverse effects of neuraxial opioids. Adverse effects from neuraxially administered opioids are potentially due to the cephalate spread of opioid in the CSF. Intrathecal and hydrophilic opioids are more likely to cause adverse effects due to cephalate migration. Adverse effects can also be due to systemic absorption from the epidural space. Epidural and lipophilic opioids are more likely to cause central effects after systemic absorption. Most side effects are dose-related due to opioid receptor interactions, however some are unrelated. Pruritus. The mechanism is not fully understood. It likely occurs due to migration of the neuraxial opioid in the CSF and interaction with opioid receptors in the trigeminal nucleus. Features. Pruritus induced by neuraxially administered opioids are more common when poorly lipid-soluble agents are used and affects up to 70% of patients after morphine and 10% after fentanyl administered neuraxially. Pruritus is more common after intrathecal opioids and occurs within the first few hours. It is usually localized to the face, neck, and thorax. Treatment is with antihistamines, even though this pruritus is not mediated by histamine release. Naloxone is most effective, however naloxone may reduce analgesia. Ondansetron has been used to treat pruritus due to neuraxial opioids. Nausea and vomiting, incidence is 20 to 50%. Mechanism is via cephalate migration of the opioid and activation of the chemoreceptor trigger zone. Features. It is more common after intrathecal opioids and more common amongst females. Urinary retention. It is mediated by opioid receptors in the sacrospinal cord. Inhibition of sacral parasympathetic outflow results in detrusor muscle relaxation. Detrusor muscle relaxation caused by epidural morphine occurs within 15 minutes of injection and persists for up to 16 hours. It is more common in young men and with intrathecal morphine. It occurs in 30 to 40%, up to 90% of males. It is readily reversed with naloxone. Constipation can occur with neuraxially administered opioids. Depression of ventilation is the most serious adverse effects of neuraxial opioids. Incidence of ventilatory depression requiring intervention after conventional doses of neuraxial opioids is about 1%. This is the same as that after conventional doses of IM or IV opioids. It may occur within minutes of administration or after a few hours. Early ventilatory depression occurs within 2 hours of neuraxial injection of the opioid. This is due to systemic absorption. It is more common if highly lipid-soluble opioids are used and if sedative drugs are also given. Delayed ventilatory depression occurs 2 hours or more after neuraxial opioid administration. The duration when this occurs depends on the type of opioid used. It reflects the cephalate migration of CSF opioids and interaction with opioid receptors located in the ventral medulla. This is uncommon at 0.5 to 3%. It is more likely with poorly lipid-soluble opioids such as morphine, intrathecal opioid administration amongst the elderly, and if systemic opioids are also administered. Risk factors includes high opioid dose, elderly patient, concomitant use of sedatives or opioids, lack of opioid tolerance, and comorbid factors such as sleep apnea and pulmonary disease. Detection is via continuous pulse oximetry, level of consciousness, and respiratory rate monitors such as EtCO2 and humidity. Treatment is with supplementary oxygen, resuscitation according to ATLS protocol, and naloxone, which may be titrated to reverse respiratory depression without reducing analgesia. Sedation can occur with neuraxially administered opioids. This is most commonly associated with the use of sufentanil. Be wary of depression of ventilation. Central nervous system excitation. Mechanism is via cephalate migration of the opioid in CSF and subsequent interaction with non-opioid receptors in the brainstem or basal ganglia. Tonic skeletal muscle rigidity can occur and is rarely observed after neuraxial administration of opioids. Viral reactivation. Administration of epidural morphine in obstetric patients is linked to reactivation of herpes simplex labialis virus. Other side effects of neuraxial opioids includes gastrointestinal dysfunction, sexual dysfunction, ocular dysfunction, and thermoregulatory dysfunction. The WHO Analgesic Ladder recommends that weak opioids are prescribed before strong opioids when undertaking the stepwise approach in treating pain. Opioids used in patient-controlled analgesia. Definition of patient-controlled analgesia. This is a technique whereby intermittent boluses of analgesic drugs such as opioids or local anesthetics are self-administered by the patients according to their own requirements. Options for PCA includes via the intravenous route and via other routes such as epidural, intranasal, transdermal, and subcutaneous. For PCA via intravenous route, the system consists of an IV electronic opioid pump with a patient-controlled bolus facility with or without a continuous background infusion. Several settings can be set at the PCA machine, including the type of drug, concentration of drug, capacity of the syringe, bolus volume, rate of background infusion, the lockout interval, which is the minimum time between boluses, the maximum dose during a set period of time, etc. Criteria for PCA use. The patient should be awake, cooperative, competent, and educated on how to use the PCA. The staff should be trained and routinely and frequently monitor the patient using PCA-specific charts that details respiratory rates, vital sign, pain score, pump settings, and the balance of volume of drug administered, etc. PCA via the IV route. Patient-controlled analgesia is an alternative to intermittent bolus dosing of opioids by healthcare workers. Patients are provided with an IV electronic opioid pump with a patient-controlled bolus facility, and this allows patients to directly control their analgesic consumption based upon their pain perception. PCAs are designed to allow patients to self-titrate their dosing to optimize their pain management. It is able to avoid wide swings between inadequate analgesia and over-sedation produced from intermittent bolus dosing of opioids by healthcare workers. Advantages of PCA. It enables patient autonomy in fulfilling their own analgesic needs. This makes it particularly useful in those who might otherwise be reluctant to request analgesia. The patient's anxiety and distress are reduced, and analgesic consumption actually tends to decrease. There is increased patient satisfaction. Only regional techniques are rated superior to PCA in patient satisfaction surveys. PCAs avoids intramuscular injections. saves nursing time and reduces staff workload. It may limit the potential for drug administration errors, and PCAs are able to cope with the wide variability of patients' requirements for post-operative opioids. PCAs are generally safe and efficacious. Controls of the PCA machine are inaccessible to the patient or relatives. Measures exist to prevent overdosage from accidental reflux of opioids into IV infusion sets and subsequent IV flushing into the patient. A dedicated separate IV lumen is used for a PCA. A one-way valve or anti-reflux system is employed to prevent opioid reflux into the IV fluid line should the cannula become blocked. The maximum possible rate of administration is limited to avoid acute toxicity. The dose is adjusted to achieve analgesia without excessive sedation. There is little tendency for the patient to use excessively large doses and become dependent. PCA provides more consistent plasma drug levels when compared with standard IM techniques. Thus, less adverse effects occur when compared to more conventional analgesic administration regimens, and there are less episodes of breakthrough pain. Drugs with relatively short half-lives are usually employed to reduce the risk of toxicity. Newer designs of PCAs enable patient mobility as they can be carried with the patient, and they also have the facility to track demand and the total analgesic dose delivered. Disadvantages of PCAs: it may lessen direct personal contact between the patient and nursing staff or doctors. Older bulky electronic pumps can limit mobility. Patients or staff may hack and steal stored opioids in PCA machines for drug abuse. Being a system that delivers bolus doses of analgesics, this may result in peak and troughs of effect. These effects can be overcome by adding a background infusion at the expense of reduced safety. Opioids can cause various adverse effects, such as nausea and vomiting, respiratory depression, sedation, pruritus, and if petidine is used, norpetidine toxicity. Risk of overdose or adverse effects. Causes includes wrong drug dilutions or dose, wrong PCA machine settings, patient's misunderstanding of the technique, equipment malfunction, administration of additional conventional on-demand opioid analgesia, accidental reflux of opioids into IV infusion sets and subsequent IV flushing into the patient. Naloxone should be prescribed if there is opioid overdose. Breakthrough pain can occur with PCAs. Causes includes malfunctioning IV line, empty syringe, faulty machine, the patient falling asleep and did not self-administer opioids via PCA, inadequate non-opioid analgesic coverage, inappropriate PCA regimen, etc. Examples of drugs used in PCAs. Morphine. This is the drug of choice for use in PCA regimens. It offers the best compromise between the combination of efficacy and duration of action. However, it has a slow time to peak effect, thus it is by no means the most suitable agent. There is little evidence of superiority of one opioid against another across patient populations using PCA. Regimens: typically 1 mg bolus with a 5-minute lockout time and no continuous infusion. Concentration: 1 mg per ml. The usefulness of background infusions is controversial and is not recommended for opioid-naive patients. The risk of overdosage should be balanced by potentially improved analgesia. If it is used, typically it is administered at 0 to 2 mg per hour. Bolus dose can range from 0.5 to 2 mg. Bolus interval can range 5 to 10 minutes. Petidine. The peak effect is achieved around 7 to 8 minutes after administration. Examples of a regimen: bolus dose of 10 to 20 mg with a 5 to 15 minute lockout time at a concentration of 10 mg per ml. Petidine should not be given for 3 days or more to avoid norpetidine accumulation, which has convulsant actions. Fentanyl. Peak effect is achieved around 5 minutes after administration. Duration of action is about 30 minutes to 1 hour. Regimens: typically bolus doses of 10 to 20 mcg with a lockout time of 5 to 10 minutes. Concentration is 10 mcg per ml. Basal rate is not recommended for opioid-naive patients. However, if used, it can be run at 0 to 60 mcg per hour. Bolus dose ranges from 10 to 50 mcg. Bolus interval 5 to 10 minutes. Tramadol. at a concentration of 10 mg per ml, bolus dose of 10 to 20 mg, and a lockout interval of 3 to 5 minutes. For diamorphine, use at a concentration of 0.5 mg per ml, bolus dose of 0.5 to 1 mg, lockout interval of 3 to 5 minutes. Remifentanil or alfentanil. The onset time of remifentanil and alfentanil is very short at around 1 to 2 minutes. However, its offset time is very rapid, and this limits their suitability for PCA systems. Remifentanil has been used to treat labor pain. Indication: the presence of a condition which contraindicates epidural analgesia, and the unavailability of personnel to place an epidural catheter. Regimens. A typical regimen would be 20 to 40 mcg bolus with a 2 to 3 minute lockout period. A regimen of 30 mcg bolus doses at 3-minute intervals results in a plasma concentration of 2 to 4 nanograms per ml. This is usually sufficient to relieve the pain of uterine contractions. Dose adjustments. If side effects such as respiratory depression and nausea occur, the bolus dose may be reduced to 20 mcg. If there is insufficient pain relief, the bolus dose can be increased to 40 mcg. Pain control and patient satisfaction. Certain studies demonstrated that patient satisfaction was greater for PCA remifentanil than epidural analgesia, while some studies suggest otherwise. Safety. A recent study reported frequent apneic events and deeper desaturations in women on remifentanil PCA compared to epidural analgesia. PCA remifentanil may be a safe labor analgesic modality in selected clinical indications if there is appropriate monitoring from personnel continuously present in the room with the patient. Nalbuphine can be used for PCA with a bolus dose of 1 to 5 mg and a lockout interval of 5 to 15 minutes. Oxycodone can be used as well at a bolus dose of 0.5 to 2 mg and a lockout period of 5 to 10 minutes. Useful tips. All patients should receive an adequate loading dose of the chosen opioid prior to commencing the PCA. Non-opioid analgesics should be prescribed if there are no contraindications, such as NSAIDs, paracetamol, regional or local anesthesia. Background opioid infusions are generally avoided except for opioid-tolerant patients or young children. For opioid-tolerant patients, the background infusion is calculated based on their daily intake of morphine or methadone. Oral morphine to parenteral morphine ratio is 2 to 1. Oral methadone to parenteral morphine ratio is 1 to 1. Safety or utility functions. This is constructed by estimating the difference in probability of analgesia and respiratory depression from pharmacokinetic and pharmacodynamic analysis. UFOs are context sensitive. It may be defined for various endpoints. Typically, it is defined as analgesia at 50% or more and respiratory depression at 50% or less. A negative UFO value indicates that the probability for respiratory depression exceeds the probability for analgesic efficacy. A positive value for UFO does not mean that the opioid does not cause respiratory depression. Based on UFO values, morphine is a better drug for post-operative PCAs than fentanyl when considering analgesia versus respiratory depression probabilities. For low-dose morphine, the probability for respiratory depression exceeds the probability for analgesic efficacy. For high-dose morphine, the probability for respiratory depression is lower than the probability for analgesic efficacy. For low-dose fentanyl, the probability for respiratory depression is lower than the probability for analgesic efficacy. For high-dose fentanyl, the probability for respiratory depression exceeds the probability for analgesic efficacy. Individuals that respond poorly to fentanyl analgesia have a greater probability of development of respiratory depression. It is thus safer to employ alternative analgesics for patients who show limited analgesic effect in response to opioid treatment. Recent developments have focused on producing opioids with an improved side effect profile. There may be beneficial effects by using agents which act on more than one type of opioid receptor. Co-administration of two drugs that produce analgesia by different mechanisms enable the same degree of analgesia to be produced while reducing the intensity of the unwanted side effects produced by each drug. Examples include Targinet. This consists of both oxycodone and naloxone in a ratio of 2 to 1. Oral naloxone has a poor oral bioavailability and a greater affinity for opioid receptors in the gut than oxycodone. Naloxone preferentially binds to opioid receptors in the gut than oxycodone. Thus, opioid gastrointestinal side effects may be reduced without affecting the central analgesic effect of oxycodone. Mox Duo. This drug consists of both morphine and oxycodone in a 3 to 2 ratio. In a research done by Richards P. et al., they have demonstrated at least 50% reduction in clinically significant side effects such as nausea and vomiting and dizziness when compared to either opioid alone. However, in 2014, the US FDA has determined there is insufficient evidence to support the approval of Mox Duo, as the applicant did not provide evidence that Mox Duo is safer than morphine and oxycodone when these drugs are used individually and at comparable doses. Tapentadol. This is one molecule that has a dual mechanism of action. The first is MOP agonism. Tapentadol is more potent at the MOP receptor than tramadol. The second action is via inhibition of noradrenaline reuptake at the spinal cord, activating alpha-2 adrenergic receptors in the spinal cord dorsal horn. Potency. Although the affinity of tapentadol for MOP receptors is 50 times lower than that of morphine, due to the synergistic dual mechanism of action mentioned above, tapentadol is able to produce potent analgesia. It is equianalgesic to oxycodone. Tapentadol is used to treat moderate to severe acute pain. It is also used to treat moderate to severe chronic pain. By reactivation of descending inhibitory pathways, tapentadol produces analgesic effects in chronic neuropathic pain patients. Compared to tramadol, tapentadol is one molecule that has a dual mechanism of action. In contrast, tramadol is a racemic mixture of two enantiomers, with each enantiomer having a different mechanism of action. Unlike tramadol, tapentadol does not inhibit neuronal reuptake of serotonin. This results in a lower incidence of nausea and vomiting. Tapentadol's low affinity for the MOP receptor may limit undesirable side effects mediated by this receptor, such as GI side effects. In contrast, tramadol's main metabolite, orthodesmethyltramadol, has high MOP receptor affinity. Sabranopardol. This is a synthetic opioid. It is an agonist at all 4 opioid receptors. It has highly potent agonistic activity at nociceptin and other opioid receptors. It has anti-hyperalgesic effects due to its activity at NOP receptors. It has less respiratory depression and abuse potential. Phase 2 of clinical development has been completed, demonstrating good efficacy across a broad range of preclinical pain models and good tolerability. Ketamine is an NMDA receptor antagonist. This action provides anesthetic properties. Ketamine also has affinity for multiple receptor systems including the opioid receptors. Its analgesic effects are predominantly due to MOP receptor activation. Kindly refer to the video on ketamine for further details. These are my references. Thank you.